Yes, many thanks for having me. One might think that I've done quite a lot of talking about all of this over the years, but in fact I haven't. So what you're hearing tonight is probably a little bit of a first, because whilst the New Zealand College of Midwives have done a fantastic job of talking the talk and walking the walk about New Zealand's maternity system, it has never really been explored from the point of view of those who worked inside the system to bring about those changes. So just to set the scene a little bit, and then I'll explain what I'm going to cover. But New Zealand, so, why am I giving this talk tonight? Why now? And why me? So New Zealand has a national continuity of care and maternity system, and all women get to choose who they want as their lead maternity carer. Now, sometimes, of course, they might struggle to find the one that they want, but in principle, the idea is that women will choose. Now, they can choose a midwife, they can choose a private specialist. Some will choose just to go to the hospital, and very few now will choose a GP obstetrician, more so in the past, less so now. So the 94% is really the number of women who are choosing to have a midwife as their lead maternity carer. About 6% choose a private obstetrician. So why am I talking about this now, 30 years on? Well, it is because it is 30 years on. Excuse me. And I think that's important, because the system has really proved its point to a large degree. And I'm going to talk later a little bit about what works and what doesn't work at the moment. So we have good outcomes of care. And in the resources, there is quite a lot of information about the outcomes of care, and I'm not going to go into those in great detail. So why me? Why am I talking about this? Well, two things happened last year to me. I've retired from work, and I came across two things that made me think I need to get back into this maternity space. One was the ICM's push for midwifery, seeing the numbers and what a difference we could make in the world with more midwives really blew me away. And the second thing was a Commonwealth Fund report, and that's in your resources, looking at comparing the US with other high-income countries, looking at maternal mortality ratios. And I'll just hold up, you may be able to see, you may not, that little graph. Now here's the US, and down here is New Zealand. Now that astonished me. I thought, my goodness, we really must be doing something right. So what have we done, and what are we doing, and what can we do better at? So that's led me into thinking I want to do more research, more study in the whole area of maternity care. Why aren't we doing better in some places? What could New Zealand do better, even still, etc. So I was the lead maternity manager on the Joint Regional Health Authorities Maternity Project from 1992 to 1996. Now, was that a long time ago? Yesterday, was it yesterday? My son would always say to me when I talk dates like that, he'd say, was that before or after Macdonald's, Mum? Well, I can tell you 1992 to 96 was after Macdonald's, but it was about the time of the internet. And I think I got my first computer in my office when I took up this job as the lead midwife. So in New Zealand, following Helen Clark's amendment to the Nurses Act, which was in 1990, Midwives were no longer required to work under the supervision of a doctor. Now, that caused a bit of chaos, I'd have to say, I think. Doctors were not happy. There was a lot of controversy about it. And because the midwives were able to access the maternity benefit schedule, and really women were really able to choose to have an obstetrician, a GP and a midwife all involved with their care all at the same time, it meant that the fees went through the roof. So the joint RHA maternity team was formed as part of the health reform process of that time. It was a very small team, and we were responsible for redesigning the maternity system, managing a capped budget, and working through the changes that needed to happen to make the system sustainable. So there are some descriptions in the, there's been a lot of research done on the midwifery maternity system in New Zealand. And I have just included one or two very good papers, one from Greg and Tracy, which I think is a very good description in the resources, and another one which looks at the question by Dawson, which looks at the question of equity, which we're probably not doing quite so well on. I'm going to talk through what I think were the critical 5 elements that we put in place and that are still in place. So the most important, I'll just run through these briefly to give you a feel where I'm headed, and then I'll go into them each in detail. So the most important was the information from and to women, the service specifications, the bundled payment system, agreements between health professionals and hospitals, and the monitoring of outcomes. Now, some of you will say, oh, we've heard all that before, it's a bit of a yawn. But I want to just go through each of those in detail because I think they are the critical factors which have made the system what it is today. So the information from women, we did a huge amount of consultation, and I mean really considerable consultation over a long period of time with many, many, many groups of women across the country. So I'm talking about Māori women, Pacific women. We had help from our Māori health team colleagues. We had help from our Pacifica colleagues to do this work. We met with disabled women. We travelled across the country. The 4 maternity managers in each of the 4 regions all took responsibility for consultation in our own regions, and we went out with our teams to do that. And we heard consistently from women, as you all know, they wanted continuity of care. That was probably the most consistent message we heard, and this was 30 years ago. So that became really an absolute pivotal point for us. And that led us on, of course, to the notion of the lead maternity carer. The second point, I'll come back to the issue of information to women rather than from women. But I will come, and of course, women told us lots of other things. They told us many, many things that were needed at that time. And I'm not going to go into those in detail. But they all formed our view over the coming 3 or 4 years of our work. So then from that, we developed the service specifications. And we developed the service specifications for primary maternity care, which was the lead maternity carer. And we developed facility specifications, secondary, tertiary, neonatal, etc. And with each draft of those service specifications, they went, there were 4 main drafts, and they went to the health professional groups, and they went out to all the women's groups again. And in fact, somebody the other day found a copy somehow on the internet of the first draft, and handwritten on the front of it was all the women's groups that person or a person had sent on to other women's groups. So that's how the networking worked. And so there was very detailed work over a long period of time to develop what then became was then called the Section 51 notice, a terribly boring title. I'll just hold up for you. It looks like this. Not very, well, a bit boring looking, but incredibly important. It still looks pretty much like that. It became the Section 88 notice, which became the primary care notice. So those are things that anybody who's looked into the New Zealand system will be familiar with, because that is actually what runs the system. That is what tells the providers what is required of them. That is what tells women what they can expect, etc. Now, our vision at the time was, oops, I'm dropping my papers, I'm just going to read a little bit here. The prime focus of maternity services will be the woman, baby, and her family or whanau, which is family in Māori, and their identified needs as they relate to pregnancy, birth, and parenting. The quality of the services provided and the safety of the mother and baby will be paramount, including cultural safety for all women, and particularly for Māori women and their whanau. And it goes on. Now, I've had a look to see how much the wording has changed to the current version, and not a lot. It's been slightly updated, of course, to slightly new language, but the objectives of the primary maternity service are to give each woman, her partner, and her whanau or family every opportunity to have a fulfilling outcome to the woman's pregnancy and childbirth by facilitating the provision of primary maternity services that are safe, informed by evidence, and based on partnership, information, and choice, and recognise that pregnancy and childbirth are a normal life stage for most women. So you can see that's developed, but not changed a great deal in terms of intent. So the third aspect was capping the total budget. And I'm not going to go into that in a great deal. We said this is the amount of money that is now being spent in maternity care at that point in 1993 or 4. This is what we're going to cap it as, no more, no less. Now, of course, we put in provision for inflation over the years and so forth. And of course, the midwives have had to argue strenuously for more than that, as they have rightly done so over the years. So not a perfect system, and the College of Midwives would like to see a different contracting model now. However, it is, as it was, a bundled payment system. Then we put in place agreements between the health professionals and the hospitals. So access agreements between the midwives and private specialists in the hospitals. And there's a template for those I've put in the resources. And most importantly, the referral guidelines. And I would have to say, I would really stress that the importance of the referral guidelines. I don't really see how a system can operate without there being complete agreement between midwives or primary carers and secondary carers. Because as we all know, that's where it can fall apart if there isn't that agreement. I'm just going to have a sip of water. So what interests me, and I think probably will be the subject of my dissertation, is why are the referral guidelines in different countries so different? And I don't mean the clinical detail. I mean the structure and format and process of the referral guidelines. Even between Australia and New Zealand, they are completely different, and yet we are it is the one college of ONG specialists and two colleges of midwives that work enormously closely together, the New Zealand and the Australian College of Midwives. And yet I've seen written that these referral guidelines are similar, but I don't think they're similar at all. I think they're vastly different. And I want to explore that a little bit more and how they work, and are they working, to what extent are they working? And then the fifth thing is the monitoring. Of course, we needed to put monitoring in place. That faltered to begin with because the regional health authorities were amalgamated. We had a change of government in about 96, I think, as 97, and we were amalgamated, and many of us lost our positions and so forth. And the monitoring was very slow to start, which was unfortunate. But it is very robust and rigorous now. And I have put the National Monitoring Group's report on the resources, and I've also put a link to the web tool that the ministry uses for monitoring maternity services, and that gives you your outcome data and so forth. So back to one, info to women. We then needed to make sure women understood these changes. So again, we had to go out and we had to write everything in a language that women were going to be able to follow. We put brochures in Pacific and Māori. We did a beautiful little brochure, which I happen to still have a copy of in my little box of tricks, expecting a special delivery. Now, you can see we have a lovely Māori woman there and two what we would call Pākehā, or English or New Zealand woman. And we have, what surprised me about this is that Aotearoa New Zealand, more and more New Zealand is being called Aotearoa, which is the Māori word, Aotearoa New Zealand. And I am surprised to see that we had that there all those years ago. But this was the brochure that was sent out to women, telling them about the maternity changes, how they would know where to find their lead maternity carer, etc. So we did a lot of a great deal of work in that regard. But interestingly, 30 years later, the National Maternity Monitoring Group still find that women don't necessarily know how to find a midwife. And of course, because there is a shortage of midwives in New Zealand, they sometimes can't find their midwife. And so consequently, there is still a great deal of work still needs to be done. Women are not always able to access a lead maternity carer early enough in their pregnancy. And there has been a lot of work done by the College of Midwives in this regard, and continues to be so. So how do we think the system is working now? Well, I think the monitoring group's report is an excellent report on what still needs to happen, what still could be improved in the system. And equity is certainly an issue. We still don't have the outcomes we would like to see for Māori and Pacific women, for young women, for women from lower socioeconomic areas, etc. All of the things that we see elsewhere. Perhaps they're not as, perhaps we have made more improvement in New Zealand over the years, but still not enough. The other thing I've mentioned already is the sustainability. The length of career for a LMC midwife is worryingly short, because how sustainable is it to be on call 24/7? Now, some of them, of course, work in teams. Most of them work in small teams, but it is a difficult situation. And it's a shame that a lot of our GPs have dropped out of maternity care. How sustainable was it for them? When you're trying to travel across town and so forth to leave your busy practice. But it has, it has meant that there is less choice for women where we had intended there was more choice for women. And I think it's something that's happening globally, of course. GPs, I mean, in Australia, they are absolutely the rock bed of maternity care because of the vast distances women would have to travel and do have to travel. So the small rural hospitals need the GP obstetricians. But in New Zealand, yes, it certainly did change. So from the point of view that I speak, which is inside the room, as I call it, those are probably the key things that happened. But I do have to acknowledge that there was a huge amount of other work that happens. The College of Midwives, the New Zealand College of Midwives work in this regard is just exemplary. And the midwifery training colleges, the universities training the midwives, absolutely fantastic. The women's groups supporting the system have, you know, there are the ONG specialists supporting the system. Absolutely critical. I think that I hope I've given you, I'm going to wrap it up. I think I'm probably about my time soon. I hope that I have given a little bit of a sense of what it takes and what it took. It took a lot of courage. We had to negotiate. I think it took this document here, which says, where is it? Something about July 1994, maternity services 1994 and beyond. Well, we didn't actually put them in place until 1996. So it took 2 years of very solid draft after draft, going through every line of every draft with the College of Midwives, with the College of GPs, with NZMA. We never really actually reached agreement. We could have had agreement with one party or agreement with the other. We could not get agreement with both parties. And eventually, in 1996, we said, that's it, and we issued the notice. And once we'd issued the notice, the only way it could be changed was redoing that consultation all over again. So in a way, that simple legislative act really, I suppose, helped keep in place. Because as Sue said, you know, people came and went, and most of us did not carry on in maternity, but other people were able to pick up where we left off and continue on with the good work. So coming back to the why, the sense, the why is because this is what women wanted. I think it's if you want to really boil it down, that's what we heard women wanted. They wanted continuity of carer, and that's how it happened.